بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, in continuation of the musculoskeletal imaging series, we will start now to discuss the imaging of the wrist joint. You know that the reasons for examination of any joint by MRI are most likely those located to the joint itself in the form of pain, trauma, swelling of the joint, or whenever there is a clinical suspicion of inflammation or tumors based on previous examinations or just on a clinical evaluation. Then, in order to examine the wrist joint by MRI, we should use the surface coil. There are dedicated surface coils for evaluation of the wrist. You can put the hand of the patient in supination or pronation, as you can see here. And sometimes whenever you are going to inject the patient with contrast media, or if you will give him some sedation, you may instruct him to be to fast about 6 hours if he is an adult, or 4 hours for the pediatric patients. You know that we have different types of MR machines, the closed magnet and the open magnet, as well as the extremity magnet, which is suitable for evaluation of the elbow and the wrist joints. The technique of examination includes the use of the surface coil and the selection of the suitable field of view, which is very important that you select the appropriate field of view in the wrist and in the ankle joints. The appropriate field of view is, according to the literature, from 8 centimeter to 12 centimeters. What happens usually in the clinical practice that the operator selects a larger field of view so that he can examine the patient in a shorter time. If you selected a large field of view, let us say 16 centimeter, or even in some cases they select 20 centimeters, then you cannot see the details of anatomy or pathology in the provided images. And then the radiologist should insist to select this suitable field of view. And we have to examine the wrist in the T1 and T2 weighted images, and also in different planes. And usually we have in the coronal T1 and gradient and stair images, and we have axial T1 and T2 weighted images, and we usually have a sagittal T2 or gradient image, which images which are usually helpful in evaluation, especially of the phalangeal pathology. Then this is the axial images. You can select the axis of the image, as you can see here. Then you start the coronal exams from anterior to posterior, or from posterior to anterior, any direction you select. And perpendicular to this plane, you can examine the sagittal images from medial to lateral, or from lateral to medial. Sometimes you can select one of the carpal bones, particularly discophyte, which is frequently injured, and there are some pathologists confined to this particular bone, then you may concentrate your examination taking special orientation of sections going along the long axis of this particular bone. As you all know that we judge the pulse sequence by the appearance of the bone marrow. The bone marrow contains fat. Fat will be bright in the T1 weighted image, less bright in the T2 weighted images, less bright in the gradient images, and dark or very dark in the stair images. And you should know also that the T2, the gradient, and the stair images all belong to the T2 weighted image, meaning that the fluid will appear black in the T1 and bright in the T2 weighted images. Fluid will appear bright here also and bright here in the stair images. And what are the structures which appear black in the T1 and T2? They are fixed structures like the cortex of the bone, mature fibrous tissue, ligaments and tendons, and calcium. In the rest, the triangular fibrocartilage normally will appear of low signal in the T1 and the T2 weighted images. Fluid will show low signal in the T1 and high signal in the T2 weighted images. This is an example of fluid which is black in this T1 and bright in the T2. The fat will be opposite the fluid. The fat will be bright in the T1 and dark in the T2 weighted images, as you can see for the bone marrow fat or the subcutaneous and intramuscular fat planes. The approach for the wrist joint is somewhat different from that of the knee joint, and I will explain at the beginning of discussing any of the joints the usual or the most reasonable approach, in my opinion, to handle the joint and to go through the anatomy and the pathology. The approach of the wrist joint depends on the pathology, and we will have some anatomic details. Then we'll discuss ligamentous injuries and injuries of the triangular fibrocartilage complex. Then we'll have some knowledge about the carpal tunnel syndrome and fractures and avascular necrosis around the wrist, and some of the other conditions that will be handled also: the ulnar variance, the ulnar impaction syndrome, ganglion cysts and tenosynovitis, and finally the carpal coalition. Starting by the anatomy, you know that the radius and ulna articulate with each other in the distal radioulnar joint, and you know that there is a notch in the distal part of the radius which is known as the sigmoid notch. This is the sigmoid notch where the ulna can articulate with the radius in this distal radioulnar joint. This joint is best evaluated in the axial images, but it can also appear in the coronal images. This is the radius and this is the ulna. This is the distal radioulnar joint. Then you have the radiocarpal joints between the radius and the carpal bones, and the mid-carpal joint between the carpal bones themselves. Then the distal radioulnar joint is the articulation between the radius and ulna through the sigmoid notch. The sigmoid notch articulates with the ulna, and anyone can palpate the dorsum of his wrist will feel this bony projection, which is known as Lester's tubercle on the dorsal surface of the radius. This tubercle is important in anatomy because it is considered an anatomic landmark for this tendon and these tendons as well. I will discuss this in a moment. And if you put the hand in the supination or in the pronation or in the neutral position, like the lateral view of the wrist by the X-ray, then there should be some changes in the relation of the ulna to the radius in different positions. In the supination, the ulna will be displaced slightly towards the volar surface of the wrist, while in pronation, the ulna will be towards the dorsal aspect of the wrist. In the neutral position, the ulna will fit directly into the sigmoid notch. So, before interpreting a certain pathology in the distal radio-ulnar joint, you should know the way by which the patient was examined. Starting by the carpal bones. And you know that there are a lot of ways to remember their names, but I recommend to you the simplest way is by remembering their accurate names. You know that this is the radius and this is the ulna. This is the most important, in my opinion, bone in the carpus, which is the scaphoid. And you know, next to the scaphoid is the lunate bone, then the triquetral. And you know that the basiform is here, but it does not appear because it is not on the same plane of these carpal bones. You can appreciate the basiform in the plane X-ray. Then the last bone in this row, according to MRI, is the triquetrum, which ends by the letters UM. Then the first bone here in the distal and the distal row of the carpal bones will start also by the UM, and this is the trapezium. Next to the trapezium, its sister, which is the trapezoid. Then you got the capitate and hamate. Finally, you have the carpal bones. Then if you look carefully here, this is the radius and this is the ulna, then this is the scaphoid, this is the lunate, and this is the triquetrum. Between the scaphoid and lunate, there is an important ligament which is known as the scapholunate ligament. This scapholunate ligament is pyramidal in shape and is insinuated between the bones, both bones. Also, there is a small ligament between the lunate and the triquetrum, and this is the lunotriquetral ligament. This ligament is horseshoe in shape, and many times it is absent, and this is considered a normal variant. And injuries of the scapholunate ligament are important. This ligament is injured usually at its mid portion, and you can appreciate this ligamentous injury more better if you have MR arthrography of the wrist. This is the scaphoid, this is the lunate, and the scapholunate ligament is torn at its middle part. According to Mayo Clinic, there are different appearances or types of the scapholunate ligament. This is type 1, which is considered normal. Type 2, there is an abnormality within the triangle of the scapholunate, and this is degeneration. Type 3, the apex is missing. Type 4, the base is partially affected. And type 5, which indicates the full thickness tear of the scapholunate ligament. You can see here the configuration of the ligament and the site of the tear. This is also an example of scapholunate ligament injury. You see the defect within the ligament. This is the scaphoid, the lunate, the triquetral. The lunotriquetral ligament is absent, as I have said. You can diagnose a scapholunate ligament tear from the plain X-ray whenever you see that the space between the scaphoid and the lunate is abnormally wide, and this is known as the scapholunate interval. If it is like this, then you suspect injury of the scapholunate ligament, and you can see it by MRI. This is the scaphoid, and this is the lunate, and this is the site of the tear. And here, the scapholunate ligament is, the scapholunate interval is wide, and you cannot see the scapholunate ligament, which is tall. Also, this is an injury which is usually also seen in the clinical practice. You see the scapholunate ligament, the triangle. It has an attachment to the scaphoid which is weaker than its attachment to the lunate. And if it will be torn from one of the attachments, it will affect the ligamentous attachment to the scaphoid. Then we came to the tendons, and you know that the tendons around the wrist are numerous. Then I would like from you to slightly concentrate with me so that you are able to remember all of these tendons around the wrist, those on the volar aspect and those on the dorsum of the wrist. You know that this is the trapezium, and this is the trapezoid, this is the capitate, and this is the hamate. The hamate has a famous hook. The trapezium has a small tubercle. Between the tubercle of the trapezium and the hook of the hamate stretches the flexor retinaculum. And the flexor retinaculum will cover the carpal tunnel. The carpal tunnel will contain the tendons of the flexor digitorum superficialis and the profundus. And it also contains the median nerve, which can be identified by its intermediate signal compared to the dark signal of the tendons. Whenever you put your finger on the median nerve and you go to the dorsal aspect, the tendon which is immediately dorsal to the median nerve is the tendon of the flexor pollicis longus. Then inside the carpal tunnel, you see the flexor digitorum, profundus, and superficialis. You cannot discriminate those from others, but you can easily appreciate the median nerve and then go dorsally, and this is the tendon of the flexor pollicis longus. Then look carefully here. If you are cutting the wrist proximal to the level of the flexor retinaculum, you know that this is the ulna and this is the radius. Then these are the flexor tendons and these are the extensor tendons. In order to remember the flexor tendons, you know that most of these are the flexor digitorum superficialis and profundus. And you identify the median nerve. Then immediately dorsal to the median nerve, go like this, and this is the tendon of the flexor pollicis longus. Then on the ulnar side, you will see the flexor carpi ulnaris. On the radial side, you will see the flexor carpi radialis. These are the flexor tendons. As you know, this is towards the radial side, this is the flexor carpi radialis. Towards the ulnar side, you will see the flexor carpi ulnaris, and most of the other tendons will belong to the flexor digitorum profundus and the superficialis. This is the median nerve, which is of intermediate signal, and dorsal to the median nerve immediately you will see the flexor pollicis longus tendon. And you remember, this is the trapezium, trapezoid, capitate, hamate. And this is the hook of the hamate. This is the tubercle of the trapezium. And this is the flexor retinaculum, which is stretched between the tubercle of the trapezium and the hook of the hamate. And you can identify the median nerve, and you can identify the flexor pollicis longus dorsal to it. Then what about the tendons on the dorsum of the hand or the wrist? I would like to draw a line like this, and you will know the benefit of this line immediately. You know, if you have here a flexor carpi ulnaris, then you should have an extensor carpi ulnaris. If you have here an flexor carpi radialis, then you should have here an extensor carpi radialis. And if you have here the flexor digitorum profundus and the superficialis, then you will have the extensor digitorum. Okay, this is good. This is the extensor carpi ulnaris, and this is the extensor carpi radialis, and this is the extensor profundus. Then you remember, this is the median nerve, and this is the flexor pollicis longus. Then this tendon is the extensor pollicis longus. Okay, what about this and what about these? And you know that on the radial side, the flexor carpi radialis is represented by two extensors, which are the extensor carpi radialis longus and brevis. Also, the flexor pollicis longus is represented by two, which are the extensor pollicis longus and the extensor pollicis brevis, which is located here. And if you look to the drawing, you will see another tendon which also belongs to the pollicis, and this is abductor pollicis longus. Okay, if you remember the flexor tendons, flexor carpi ulnaris, flexor carpi radialis, flexor digitorum, flexor pollicis. Then, on the ulnar side, one by one, flexor carpi ulnaris, extensor carpi ulnaris, flexor digitorum, extensor digitorum. Flexor pollicis longus will be represented by two, extensor pollicis longus and extensor pollicis brevis. Flexor carpi radialis will be represented by two, extensor carpi radialis longus and brevis. And you will add another tendon here, which is the abductor pollicis longus. Okay. The triangular fibrocartilage is a fibrocartilage triangle which separates the ulna from the carpal bones. The appearance of this triangular fibrocartilage as a triangle is seen in the axial images, but you can see it in the coronal and sagittal images. Looks like the intervertebral disc, for example, disc-like structure. And in the plain X-ray, you can imagine its site here. If you inject a contrast media inside the joint doing arthrography, then this filling defect will represent the site of the triangular fibrocartilage. The triangular fibrocartilage connects the ulnar styloid process to the medial surface of the radius. It will appear as a triangle in the axial image with its apex at the ulnar styloid process. And you know, this triangular fibrocartilage is very important for stabilization of the distal radioulnar joint. So, if this triangular fibrocartilage is torn, you will get abnormal relation between the ulna and radius through the distal radioulnar joint. This is the appearance of the triangular fibrocartilage in the coronal image. And you see disc-like structure of low signal in all pulse sequences. Also, in the sagittal images, look for the distal end of the ulna, and more distally you can see the disc-like structure which represents the triangular fibrocartilage. Triangular fibrocartilage attaches to the ulnar styloid process by two fascicles. Then you can see one limb and another limb with a gap, or let us say an abnormal signal in between the two fascicles, and this is considered normal. Also, one of the normal findings is that whenever you reach the ulnar attachment of the triangular fibrocartilage, and you can see some intermediate signal, and this represents the articular cartilage of the radius extends through the base of the triangular fibrocartilage. This is considered normal. This is considered normal. Intermediate signal at the base of the triangular fibrocartilage near its radial attachment represents the radial articular cartilage going through the base of the disc. Then there are two fascicles, as I have said, attaching the triangular fibrocartilage to the ulnar styloid process, and there is an intermediate signal at the base of the disc representing the articular cartilage of the radius extending at the base of the triangular fibrocartilage. Then what happens if this triangular fibrocartilage is torn? And you know that there may be pain, there may be volar tear will cause dorsal subluxation, dorsal tear will cause volar subluxation of the distal radioulnar joint, and massive tear will cause dislocation in any direction. And here you can see that there is abnormal relation between the head of the ulna and the radius with disruption of the radioulnar joint. And you should remember that traumatic tears of the triangular fibrocartilage usually occur near the radius in younger patients, while degenerative tears usually occur near the ulna in old patients. Then, if you look carefully here, and you see that the triangular fibrocartilage is not reaching the radial attachment, there is a defect here, and this is tear near the radial attachment, you know that if the triangular fibrocartilage is torn, there will be leakage of contrast or joint fluid into the distal radioulnar joint. This is one of the values of sagittal images, is to assess the integrity of the triangular fibrocartilage. This is normal, and this is torn at its middle part. And here there is a defect or avulsion of the ulnar attachment of the triangular fibrocartilage with leakage of contrast between the triangular fibrocartilage and the ulna. Also in this image you can see there is tear of the scapholunate ligament. This is also an example of a triangular fibrocartilage injury at this particular site, which is seen in the T2 weighted images and in the gradient images as well. You see the site of the tear. Then tear of the triangular fibrocartilage in this particular example, and you see this is the site of the tear, this is the rest of the triangular fibrocartilage, and this is the normal attachment of the triangular fibrocartilage to the radius. The defect is here. And this is also a focal tear of the ulnar aspect of the triangular fibrocartilage here. And this is the rest of the triangular fibrocartilage. This is the normal attachment of the cartilage to the radius. Then what do we mean by ulnar variance? Normally, the ulnar articular surface is usually at the same level, forming a smooth curve with the radial articular surface. But if the ulna is shorter, let us say shorter than the radius, and this is known as negative ulnar variance. If the ulna is relatively longer than the radius, then you call it positive ulnar variance. Any type of ulnar variance will affect the triangular fibrocartilage, either by degeneration or by tear. And you see that this ulna is shorter than the radius, and the triangular fibrocartilage is swollen, and it shows intermediate signal denoting its degeneration. This is negative ulnar variance with degenerated triangular fibrocartilage. This is positive ulnar variance. You see the ulna, and the triangular fibrocartilage is intact but is markedly deformed, as you can see here. And this is if the ulna is more, let us say, longer than the radius, it will impact against the lunate bone. And you remember that the triangular fibrocartilage lies in between. Then, positive ulnar variance may result in tear or degeneration of the triangular fibrocartilage, and also degenerative changes in the facing portion of the lunate bone. And if this happens, this will be known as ulnar impaction syndrome or ulnar abutment syndrome. And here you see this ulna is positive, and you can see the tear of the triangular fibrocartilage and the bone marrow changes in the lunate bone. And this is positive ulnar variance with torn triangular fibrocartilage, bone marrow edema of the lunate bone, and this is known as ulnar impaction syndrome. This is also another example, and you can see the tear in the triangular fibrocartilage and also the changes in the lunate bone. Ulnar impaction syndrome is usually associated with triangular fibrocartilage injuries, lunate cartilage degeneration, lunate bone marrow changes, lunotriquetral ligament disruption, and wrist instability. This is an example of ulnar impaction syndrome by CT coronal reconstruction and MRI coronal T1 weighted image. You see the changes in the lunate bone, you see the positive ulnar variance, and if you look carefully, the triangular fibrocartilage, you can feel that there is some injury here. Then we came to the carpal tunnel syndrome. And carpal tunnel syndrome means that the median nerve within the carpal tunnel is compressed or is suffering. Let us say the median nerve is suffering within the carpal tunnel. Normally, the median nerve is elliptical in shape, and it shows intermediate signal in all pulse sequences in T1, T2, and gradient images. Then, if there is a change in the size or the signal intensity of the nerve, you consider the presence of carpal tunnel syndrome. The nerve is elliptical in shape, as I have said. A swelling of the nerve or flattening of the nerve associated with a change in the signal are diagnostic signs of carpal tunnel syndrome. Nerve swelling, nerve flattening, increased signal on T2, and bowing of the flexor retinaculum. You know, the flexor retinaculum is horizontally stretched between the tubercle of the trapezium and the hook of the hamate. And bowing of the flexor retinaculum means that there is increased pressure in the carpal tunnel, which is one of the supportive signs of carpal tunnel syndrome. The causes are a lot, starting by being idiopathic, tenosynovitis of the tendons within the carpal tunnel, fractures and scarring within the tunnel, inflammatory lesions like rheumatoid arthritis, gout, granulomatous infection, tumors of the median nerve, tumors inside the tunnel like ganglia, lipoma, hemangioma, increased volume in the tunnel due to acromegaly, hypothyroidism, diabetes, and systemic lupus. This is an example of carpal tunnel syndrome because the median nerve is flattened with increased signal. And this is also a carpal tunnel syndrome. The median nerve is flattened with increased signal. One of the ways for treatment of carpal tunnel syndrome is cutting or endoscopic release of the flexor retinaculum. And you see here there is a release of the flexor retinaculum, and this is the median nerve. And this is an example of carpal tunnel syndrome secondary to fracture of the hook of the hamate. There is flattening and increased signal of the nerve in the T2 weighted image. This is a known tumor of the median nerve, which is known as fibrolipomatous hamartoma. This fibrolipomatous hamartoma results in marked increase in the size of the median nerve. And being lipoma, you can see a high signal, and inside this high signal you can see dots or lines of black signal representing the fibers of the nerve. And sometimes they relate this to the appearance of the spaghetti. And you see here there are multiple lines representing the fibers of the nerve associated with extensive enlargement due to lipomatous infiltration. Also, simple lipoma can occur inside the carpal tunnel like this one, and they increase the pressure resulting in carpal tunnel syndrome. Tenosynovitis of the flexor digitorum, the profundus and the superficialis will result in increased pressure inside the carpal tunnel and abnormal signal and the shape of the median nerve. Also, tenosynovitis, this is an example. You see, this is the carpal tunnel, and there is fluid signal within the carpal tunnel. And here, after contrast enhancement, and you get some enhancement, meaning that there is synovial thickening and inflammation in a case of rheumatoid arthritis. This is an example of tenosynovitis of the dorsal tendons. You see a fluid signal surrounding the tendons. This is not included, of course, in the causes of the carpal tunnel. Ganglia are common in the region of the wrist joint, either in the dorsal or the volar aspect. And this is a cyst which is filled with fluid, low signal in the T1, high signal in the T2. And if you inject the contrast enhancement, the cyst will not enhance. This is still this is the T1 fat suppressed post contrast image, and you cannot see enhancement of the cyst. A few words about the ulnar nerve. Where to look for the ulnar nerve in the wrist joint? If you look carefully here, you can see that the ulnar nerve will cross over the flexor retinaculum in a special canal, which is known as the Guyon's canal. This canal is seen lateral or along the inner border of the basiform. This is the canal, and inside the canal you will see the ulnar nerve and the ulnar artery as well. Then, in order to look for the ulnar nerve, you can see it at 3 important points. Number 1, in this section, if you identify the flexor carpi ulnaris deep to it, you will see the ulnar nerve and artery. Number 2, medial or along the inner border of the basiform, lateral to the basiform, through the Guyon's canal, which is a canal superficial to the carpal tunnel. Then the last site is at the tip of the hook of the hamate. And here you can identify the ulnar nerve, also the ulnar artery. Then the 3 points looking for the ulnar nerve in the wrist joint or at the wrist joint are deep to the flexor carpi ulnaris, lateral to the basiform in the Guyon's canal, and at the tip of the hamate bone. Fractures around the wrist are common, and the most common one is the Cool's fracture, which involves the distal end of the radius with or without impaction and angulation. The diagnosis is easy, and the interpretation of the plain X-ray is usually enough in many conditions. And here in this example, you can see that there is injury of the or fracture of the ulnar styloid process, and this may result in injuries of the ulnar attachment of the triangular fibrocartilage. Sometimes post-traumatic wrist pain cannot be explained by the plain X-ray because X-rays will show normal findings, but MRI will show, as you can see here, bone marrow edema of the scaphoid bone without evidence of fractures. And this is also a scaphoid bone marrow contusion secondary to trauma. You see the scaphoid is intact with no fracture lines. Also, the hamate or any of the carpal bones can be affected by trauma, and here you can see diffuse bone marrow edema, low signal in the T1, high signal in the T2, secondary to trauma. The distal radio-ulnar joint is the articulation between the ulna and radius through the sigmoid notch. And you remember that this joint is mainly stabilized by the triangular fibrocartilage, as well as some of the tendons around the joint. Then injuries will result in dislocation or subluxation of the triangular of the distal radio-ulnar joint, which are easily evaluated in the axial images, as you can see here. Fractures of the scaphoid are considered the second most common fracture of the wrist after Cool's fracture. And the common injury is the fall on the outstretched hand, and this will result in fracture most commonly at the waist of the scaphoid bone. The scaphoid fractures usually may show some complications like delayed union or the development of avascular necrosis, especially of its proximal pole, or may be associated or result in osteoarthritic changes due to non-healing, and also may be associated with carpal tunnel syndrome. I recommend to you, if you want to examine any joint by CT, the most valuable images are the 2D reconstructed images in the coronal and sagittal planes, especially in the wrist and ankle. If you will have the axial images only, you will not be able to interpret the images. It's very difficult to see the fractures and to locate the name of the bones. But whenever you have a coronal reconstruction like this one, it's easy for you to know that this is the scaphoid and there is a fracture in the waist of the scaphoid. By MRI, you can see the fracture line in the T1 weighted image, and you can also see the post-traumatic bone marrow edema of the scaphoid bone. You know that the blood supply of the scaphoid bone reaches the scaphoid through its distal wall. Then fractures of the waist of the scaphoid will result in disruption of the blood supply to the proximal bone with development of avascular necrosis. As any case of avascular necrosis, the dead bone usually shows increased density in the plain X-ray and CT scan, and decreased signal in the MR images due to the development of bone sclerosis. This is the orientation of the blood supply entering the scaphoid bone, and this is the fracture without clear evidence of avascular necrosis in this bone. But if you look here and you see that there is a fracture in the waist of the scaphoid, the proximal bone is of low signal in the T1 and low signal in the T2 gradient and the stair. This means that there is avascular necrosis of the proximal bone. And there are some suggestions that if you inject contrast media and there is some enhancement in this apparently necrotic bone, you may consider residual viability. And look here, and this is the scaphoid, and most of the scaphoid bone is edematous, showing high signal in the T2 weighted images except for the proximal bone. And this is most likely a necrotic bone because it is of low signal in the T1 and low signal in the T2 weighted images. Sclerosis and fragmentation are the signs of avascular necrosis in the plain X-ray and in the CT scan. And here you can see the fracture of the waist of the scaphoid with relative bone sclerosis and the development of cystic changes in the proximal bone suggestive of avascular necrosis. One of the signs of avascular necrosis in the scaphoid is what is known as the nipple sign, which means that the proximal bone is more pointing compared to the normal configuration of the proximal bone in a normal bone. Then you see the diffuse bone sclerosis and the low signal in the MRI, which are almost diagnostic of necrosis, and this is one of the signs. In Kienbock disease is the avascular necrosis of the lunate, and we have 4 stages of avascular necrosis of the lunate bone. Number 1 is bone marrow edema, and bone marrow edema will appear of dark signal in the T1 and the bright signal in the T2 gradient and the stair images. This will not be seen in the plain X-ray, but it will appear in the bone scan. Stage 2 means that there is a sclerosis of the lunate bone, and the sclerosis will be seen by the plain film and also by MRI, low signal in the T1 and T2 weighted images. Stage 3 means fragmentation of the affected bone, and this can be seen in all images. And this is a Kienbock disease with some collapse and the fissures and increased bone density of the lunate bone. Stage 4 means fragmentation, collapse, and the development of osteoarthritis in the radiocarpal joint. Ganglion, ganglion cysts are common in around the wrist. This is an example, and you see a cystic lesion which is of low signal in the T1 and high signal in the T2. This is not a tenosynovitis, but a ganglion cyst which is related to the tendon. In cases of tenosynovitis, the tendon will be in the middle part of the fluid. It's not eccentric like this, but this is a ganglion related to the synovial sheath. Carpal coalition means that there is fusion between the carpal bones, most commonly the lunate and the triquetrum. And this is an example by MRI, and you see the scaphoid, the lunate and the triquetrum are now forming a single bone. And this is the capitate and trapezium fusion or synchondrosis. And you remember, this is the trapezium, and this is the trapezoid, this is the capitate, this is the hamate. Now there is fusion between the trapezoid and the capitate bone. Then what are the values of coronal images in the evaluation of the wrist joint? Or let us say in another word, how can you read the MRI of the wrist joint? I recommend that you start by the coronal images T1 and the stair, looking for these abnormalities. Number 1, the triangular fibrocartilage, which is located along the distal end of the ulna. Number 2, look for the ulnar variance. Is the ulna longer or shorter than the radius? Number 3, look for the scapholunate ligament, which is this one, and the lunotriquetral ligament. Fractures, Colles fracture here and scaphoid fracture here. A vascular necrosis of the carpal bones, particularly the scaphoid and the lunate. Then any form of arthroposis, I will discuss this in a separate lecture concerning arthroposis anywhere in the body. Then the axial images are important. Number one, in evaluation of the distal radioulnar joint. Number two, you remember the carpal tunnel. Number three, the anatomy of the flexor and extensor tendons. Number four, looking for abnormalities in the ulnar nerve at the 3 points I have mentioned. The value of the sagittal images are directed to the evaluation of the tendons, whether the flexor or the extensor tendons. And also you can have some help from the sagittal images concerning injuries of the triangular fibrocarp. هذا وبالله التوفيق. Thank you very much. والحمد لله رب العالمين.